Chronic compartment syndrome, unlike acute compartment syndrome, is not a true medical emergency, but can be a problem nonetheless. This is due to an exertional compartment syndrome without any type of acute etiology that causes the swelling to take place. So generally speaking, the mechanism of injury is going to consist of muscle hypertrophy or an inelastic crural fascia or intermuscular septum that puts pressure on those muscles. Signs and symptoms include tightness or cramping in the compartment, a superficial fascial hernia that you may be able to actually visualize in the calf area or on the shin. Pain tends to be present with exercise and relieved with rest. And the pain is in proximal muscular region of the compartment, not so much in the distal tendon area. The individual may also complain of a squeezing sensation that's taking place. There can be neurological symptoms within the involved compartment, such as tingling and numbness. Finally, with chronic compartment syndrome, the individual will complain that with the initial 5 to 10 minutes of exercise, they really have a lot of cramping and pain, but then that tends to go away throughout the exercise and then is completely gone when the person is at rest. Range of motion wise, we're going to be looking at the exact same range of motion that we did with the acute compartment syndrome, in that you're going to look at active and passive range of motion at the adjacent joints that are involved with the compartment muscles. So even though we just have the ankle here, you may also want to do knee flexion and extension. Special tests that we will do, we are going to perform an eccentric stretch test of the compartment that is involved. When we are looking at chronic compartment syndrome or determining if this is what a person may have, we are going to use that transducer again to check the pressure. Now, the diagnosis is when a person has a resting pressure that's higher than 15 millimeters of mercury. They're asked to exercise for 10 to 15 minutes, and then 1 minute post-exercise the pressure is greater than 30 millimeters of mercury, and 5 minutes post-exercise the pressure has only decreased to 20 millimeters of mercury. We can also use some more diagnostic tests such as an MRI, the near infrared spectroscopy, and then also the ICP. Because this is not a true medical emergency, you generally will not see surgery taking place. It becomes more of a problem when sensory changes start affecting the neuromuscular control of the ankle and foot, and then surgery may be considered. In a non-herniated compartment syndrome that is chronic, there may be a fascial release that's done, but if there is a hernia that is observable, the fascial release occurs at the hernia site to decompress the nerve.